Hi, today I will be talking about outpatient evaluation and management coding guidelines. Effective January 1, 2021, the American Medical Association has established new coding and documentation guidelines for outpatient evaluation and management services. This is the biggest change for evaluation and management coding since 1997. These changes are made to simplify code selection and allow physicians and qualified health professionals to spend less time documenting and more time caring for the patient. History and physical exam components will not be required for determining the level of office visit. Coding will now be based on 1. Medical decision making, or 2. Total time spent for the visit on the day of service. There are 4 levels of medical decision making: straightforward, low, moderate, and high. There are 3 components for each level of medical decision making. 1. Number and complexity of problems. 2. Amount and complexity of data reviewed. 3. Risk of complications and or mortality or morbidity. One has to meet 2 of the 3 components for each level of medical decision making. Determining the level of medical decision making starts with identifying the number and complexity of problems and then determining the amount of data reviewed or risk of complications. For straightforward level of medical decision making, the number and complexity of problems addressed is minimal. Amount and complexity of data reviewed is minimal to none. Risk of complications is minimal. For low level medical decision making, number and complexity of problems addressed is low. Amount and complexity of data reviewed is limited. Risk of complications is low. For moderate level of medical decision making, number and complexity of problems addressed is moderate. Amount and complexity of data reviewed is moderate. Risk of complications is moderate. For high level of medical decision making, number and complexity of problems addressed is high. Amount and complexity of data reviewed is extensive. Risk of complications is high. Number and complexity of problems. For a straightforward level of medical decision making, it is one self-limited or minor problem. For low level of medical decision making, 2 or more self-limited or minor problems, or 1 stable chronic illness, or 1 acute uncomplicated illness, or 1 acute uncomplicated injury. For moderate level of medical decision making, 2 or more stable chronic illnesses, or 1 or more chronic illness with exacerbation, or 1 acute illness with systemic symptoms, or 1 acute complicated injury, or 1 undiagnosed new problem with uncertain prognosis. For high level of medical decision making, 1 or more chronic illnesses with severe exacerbation or progression, or 1 acute illness or injury that poses a threat to life or bodily function. There are 3 categories of data. Category 1 consists of review of external notes, review of labs or test results, ordering labs or tests. Category 2 includes independent interpretation of a test such as chest X-ray or EKG, history obtained from independent historian. Category 3 includes discussion of management or interpretation of test result with external physician. Straightforward medical decision making requires minimal or no data. Low complexity medical decision making requires one of 2 categories. In category 1, any combination of 2 from the following: review of prior external notes, review of lab results and test results, ordering of labs and tests. Category 2, history obtained from independent historian. Example, getting history from a parent in case of a child. Moderate complexity medical decision making requires 1 out of 3 categories. Category 1, any combination of 3 from the following: review of prior external notes, review of lab results and test results, ordering labs and test, history obtained from independent historian. Or category 2, which includes independent interpretation of a test performed by another physician. Example, interpreting a chest X-ray or EKG. Or category 3, which includes discussion of management or test interpretation with external physician. High complexity medical decision making requires at least 2 out of 3 categories. For category 1, any combination of 3 from the following: review of prior external notes, review of results or test, ordering labs or test, history obtained from independent historian. Or category 2, which includes independent interpretation of a test performed by another physician. Or category 3, which includes discussion of management or test interpretation with external physician. Coding templates for pre-op visits. Level 3 visit for low complexity medical decision making when patients are undergoing minor surgery such as cataract repair without risk factors. Level 4 visit, which includes moderate complexity medical decision making when patients are undergoing minor surgery with risk factors such as hypertension, diabetes, chronic kidney disease, coronary artery disease, or a major surgery without risk factors, plus ordering and reviewing 3 lab tests or interpreting a chest X-ray or EKG. Level 5 visit for high complexity medical decision making for patients undergoing major surgery with risk factors, plus ordering and reviewing 3 lab tests and interpreting a chest X-ray or EKG. Time-based coding. Total time spent includes time spent before the visit, which includes reviewing the medical record, seeing the patient face-to-face in the office, discussing patient care with other family members and other healthcare professionals, ordering medications and tests, documenting in the EMR, follow-up with the patient or family members later in the day with test results. Time-based coding for new patient visits. Level 2 visit CPT code 99202. Time spent should be 15 to 29 minutes. Level 3 CPT code 99203. Time spent is 30 to 44 minutes. Level 4 CPT code 99204. Time spent should be 45 to 59 minutes. Level 5 visit CPT code 99205. Time spent should be 60 to 74 minutes. Time-based coding for established patient visit. Level 2 visit CPT code 99212. Time spent should be 10 to 19 minutes. Level 3 visit CPT code 99213. Time spent should be 20 to 29 minutes. Level 4 CPT code 99214. Time spent should be 30 to 39 minutes. Level 5 CPT code 99215. Time spent should be 40 to 54 minutes. Prolonged services. Any time spent beyond the time frame for a particular level of visit can be billed under a new CPT code 99417 for every additional 15 minutes spent. For example, for a new patient visit for level 5, it can be billed as 99205 plus 99417 for every 15 minutes spent extra. In this case, it would be 75 to 89 minutes. For established patient level 5 visit, it can be billed under CPT code 99215 plus 99417 for every 15 minutes spent extra. In this case, it would be 55 to 69 minutes spent. Now let's talk about few cases. Level 2 visit, which involves straightforward medical decision making. Time for this visit would be 10 to 19 minutes for an established patient. This is a visit for a simple problem such as viral upper respiratory tract infection or a simple recheck of a stable problem during which no medication is prescribed or labs ordered. Example, subjective, a 20-year-old female who presents to the office with 1-day history of bilateral eye irritation and runny nose. Objective, vitals temperature 98, blood pressure 105/60, heart rate of 70, respiratory rate of 16. Physical exam, HEENT, mild bilateral conjunctival erythema with no drainage. Pupils are equally round and reactive to light. Assessment and plan, viral conjunctivitis. Supportive care and conservative management. Reviewed the viral cause of the symptoms and emphasized eye hygiene with the patient. Level 3 visit, which involves low level of medical decision making. Time for this visit is 20 to 29 minutes for established patient. This is a visit in which a patient comes in with a stable medical problem and no new medications are prescribed. Example, subjective, a 50-year-old male who presents to the office for follow-up of diabetes, which was diagnosed 3 years ago. He denies any other complaints. Objective, vitals temperature 98, blood pressure 120/70, heart rate of 70, respiratory rate of 20. Physical exam, heart, regular rate and rhythm, abdomen soft and non-tender, neurology, no evidence of peripheral neuropathy. Labs reviewed, hemoglobin A1C is 6.5, serum creatinine is 1 mg per deciliter. Assessment and plan, diabetes mellitus, stable, no change of medications, continue metformin 1000 mg twice daily, emphasized dietary recommendation with the patient. Level 4 visit, which requires moderate level of medical decision making, and time spent would be between 30 to 39 minutes for an established patient. This is a visit in which you address a patient's chronic problem which is not controlled and needs a new prescription and order labs or test. It may also involve one undiagnosed new problem with uncertain prognosis. Example, subject to a 40-year-old female who presents with right upper quadrant pain in the abdomen for the last 5 days, which is associated with nausea and vomiting. The pain is worse with food. She denies any diarrhea, denies any fever or chills. Objective vitals, temperature 97, blood pressure 110/60, heart rate 80, respiratory rate of 20, BMI of 28, physical exam, HEENT, no scleral icterus, heart regular rate and rhythm, abdomen soft, it's not distended, noted to have right upper quadrant tenderness. Assessment and plan, abdominal pain, suspect cholelithiasis versus cholecystitis. Labs ordered would include CBC, CMP, and ultrasound of the gallbladder. Medications prescribed would be hydrocodone, acetaminophen combination such as Norco, 5-325, 1 tablet every 8 hours as needed for pain. Level 5 visit, which involves high-level medical decision making. Time spent for this visit would be 40 to 54 minutes for an established patient. Example, subject to a 60-year-old male with history of COPD, not oxygen dependent, at home, comes to the office with acute worsening of shortness of breath for the last 3 days, that is worse with minimal ambulation. His symptoms have not been improved with the regular inhalers. He's been having cough with pleural and sputum. He denies any chest pain. Objective vitals, temperature 98, blood pressure 120/80, heart rate of 106, respiratory rate of 24. Oxygen saturation on room air was 86% and improved to 92% on 2 liters of oxygen. Physical exam, lungs, bilateral expiratory wheezing, heart, sinus tachycardia. Assessment and plan, acute exacerbation of COPD with hypoxia. Patient was placed on supplemental oxygen in the clinic. He was given 2 doses of albuterol nebulizer treatment with minimal relief. Patient will be sent to the emergency room for further evaluation and treatment. This could be a visit in which you see a very sick patient in the office who may require transfer to the ER and for admission to the hospital.